it. Okay, welcome everybody to February's edition of our journal club. Thank you guys for coming. Little shout out to IOTA and Cameo in particular, helping us out with spreading the word. I think that has been fruitful the last few months. So I'm excited to see these new faces and some faces that have been coming more recently and coming back. So I'm excited about that. But without I guess should we go through with some new people sharing who we are? Might as well. Yeah, might as well start with this. So let's go through. I'm gonna skip Corwin for right now because we'll segue that into his introduction because he is the man of the hour tonight. So let's start with Lisa. Do you want to just share who you are and maybe where you're from, since I think we do have representation throughout our state, maybe.
Hi, I'm Lisa Hong, and I am in Idaho Falls area. I do private practice and happy to be here.
Thanks for coming. And I guess maybe this is Joanne and myself, Brittany. We're OTA faculty at ISU in Pocatello.
Yes.
I have Megan Doyle, IOTA president. It's already there saying that. You can share more if you would like.
So no, just happy to support. I was about to put in the chat, but now this is my opportunity to say it out loud. I'm like, that's my social outreach chair. So kudos to Cameo getting it done. I'm so thrilled that she's part of the team. Same with Lisa Hong. She's our legislative and advocacy chair and clearly very passionate and participatory. So we're just really excited that this is something that I think is going to continue to have momentum and we can put the state association behind.
Thank you. Alyssa Shirley.
Hello, my name's Alyssa. I'm a first year MOT student at ISU, and I'm also one of the co-student representatives for IOTA. I came last month and I'm excited just to keep coming to these and to get to learn together.
Thank you for joining us. Heather Park.
Hi, I'm Heather. I'm also a first year MOT student at ISU. I'm one of Corwin's students actually, and he's a phenomenal teacher. So I'm excited to be here.
Yay, that's awesome. Cody Thomas. Maybe I'll introduce her because she...
No, I'm good.
Oh, perfect. Good.
Sorry. My name is Cody Thomas. I currently work in the school districts over in Idaho Falls area. I'm a graduate from the ISU program last year.
Yes. Wow, I was thinking the class of 2021. Time has all blended together. Oh, that's awesome. Okay, Megan Gibb.
Hi guys, so I'm based out of Boise. I'm a CWI OTA student. I'm also a co-rep for CWI for IOTA, and then this is my second time being here, so I'm excited. Thanks for allowing CWI students to join. We appreciate it.
Not a matter of allowing, yes. Everybody is welcome. We're happy to have you.
And I would love your support. And actually, I was thinking like, oh, I need to make sure Angela Zog's email is on my listserv. So if you can help, if you get these emails, which I think I have an email on it, please share with your colleagues in your cohort. That'd be awesome.
Perfect. Will do. Thank you.
All right. Anna Alexander, the birthday girl yesterday.
Yeah, don't be spreading that around. So I'm Anna. I'm an adjunct here in Pocatello for OTA, OT, Health Hawk. Yeah, just whatever I do. I do PRN at a SNF, and that's about it.
All right, thank you. Sydney Gee.
Hi, I'm Sydney. I'm an OT in Pocatello. I work for home health.
Happy to see you, even if I don't see you.
See your name.
Thank you. I'm driving, so
you're totally fine.
I'm doing pretty good to work to get on the call. So thank you.
For sure. And Cameo, her nut. Oh, you're muted.
Oh, Cameo, you're on mute.
Sorry, you caught me making dinner. My name's Cameo Kerna. I'm the social outreach coordinator for the IOTA. I apologize about my hair. I work PRN at the Veterans Home for Infinity Rehab, and I have so many more ideas for the Journal Club, but you got to crawl before you can walk. So
I'm ready to hear them. I mean, maybe later, but yeah.
Yeah.
Okay, and then last but not least, Corwin Sutherin. Well, one thing I do know about him, he is the pediatric instructor for the Master's OT program here in Pocatello. And he is a pediatric extraordinaire up at the hospital with NICU and all sorts of great experience. So thank you, Corwin, for being interested in helping us out. And I'm super excited about your topic tonight. But please share more about yourself, and then the floor is yours.
Take it away.
Okay, well, thank you. Hello, everybody. There's a lot of faces and names I recognize. So hello to all of you. It's nice to see you. I spend most of my time at Portage Medical Center in the NICU and mostly feeding. I actually do swallow studies in the radiology, which is kind of unique for OTs. And I also adjunct. I teach, like was mentioned, the pediatric course, and I also teach the kinesiology course, which is going on right now. But yeah, thank you for inviting me for the Journal Club. I'm glad I got the email a few weeks ago about, well, actually probably a month ago, about the Journal Club. I didn't know anything about it, and I appreciate the ISU OTA program for establishing this. I think it's excellent, and I look forward to in the future to listen and to learn as well with everybody else. So I'm going to try to share my screen. Okay, can everybody see that? Okay, very good. So I think everybody probably knows or has an idea what constraint-induced movement therapy is. There is some research out there, and it's ongoing. There's also some research that coming out of St. Louis that's currently ongoing, hasn't been published yet, but it's specifically for infants and children, 36 months and younger. And so it's typically done with children that have some type of a disability, typically cerebral palsy. That's what you'll find a lot of the research in. But basically, if a child has decreased use in one hand, that's a good use for constraint-induced movement therapy. So some objectives, hopefully that you'll learn something this evening. And I have to say that I'm not an expert in CIMT, but I have with some clients practice it several times, even with some infants and with some older children. Most of my time is spent inpatient, and I don't do a lot of outpatient services anymore. At the end, I do have a case study that I'll share with you of about a 2-year-old that I did some constraint and movement therapy with a number of years ago, and I'll share with you some information about that. Hopefully this evening that you can have some up-to-date information about evidence-based information regarding CIMT. And there are a lot of different research studies out there talking about the different dosage, and it can be very confusing. And at the very end, hopefully that there will be some application to practice that at the end of the evening, and you'll be able to have something to take away and to maybe even apply in your practice, or maybe even with a specific case study, a client that you have. Now, this research article comes out of the University of Utah, and it is the most current, up-to-date research article that I could find about CIMT with the pediatric population. And I know it's geared toward the pediatric population, and not everybody works with children and infants, but there is some good research in this article. And I didn't know this, but CIMT is one of the most researched interventions in occupational therapy. And I didn't realize that until reading some of this article and some different articles. And there's actually a Cochrane review, which I'll touch on a little bit, that came out in 2019. And I'll talk just a little bit about that research article. And anytime you have a Cochrane review, it's nice to say, okay, there is enough research out there to actually have a Cochrane review. And I'll talk about that a little bit later. So Dr. Terrell is from the University of Utah, and I don't know if I'm going to say her name right. Dioniso is actually a doctoral student. And this research study, I'll talk a little bit more about it. It's got a low number of cases that it talks about in journal articles, but we'll get into that a little bit later. But I wanted to talk a little bit about cerebral palsy, and this could be a whole lecture on just CP alone. But just so we're kind of on the same page, but CP is a disorder that affects typically a child or even adults, but it's usually diagnosed when they're young. The cerebral cortex is usually injured in some way, and it presents as motor incoordination or weakness or problems with functional use of the muscles. And it can be acquired, or a child can be born with some type of neurological condition. And the number this is the most recent number that I was able to find. It's from the CDC. 1 in 323 children in the United States are impacted by cerebral palsy. Now, it used to be, this was back in the early days when I was practicing, and maybe a few others out there, but normally you didn't hear cerebral palsy as a diagnosis until the second year of life. But this is changing. And it's changing because of, well, early intervention. The earlier you can work with children and work with that neuroplasticity, the better outcomes you have. And so now it's being diagnosed as early as 3 to 5 months. And a research article that I read about cerebral palsy. So they're trying to catch it earlier when children kind of come out of that reflexive stage, in about 3 to 4 months, start using their hands and trying to diagnose as early as possible to help with that neuroplasticity. So 90% of children with CP gain motor progress by age 5 as average. However, the majority of the progress is made by age 2. Okay, and as we're going along, if there's any questions or any clarifications, feel free to interrupt me. And I'm trying to keep an eye on the chat too, so if somebody has a question from there. Okay, so CIMT. So an interesting thing, I already mentioned, it's one of the most researched areas for adults and children. And if you have to think about two things, what is CIMT? Well, basically there's two key components. The first is restraint of the less affected limb, and 2 is some type of intensive structured upper limb therapy. Okay, and so the goal is to increase the use of the affected upper extremity. And most of the research is found in children that are age 2 and older, but that's changing actually within the last 2 to 3 years. There's more research for infants and younger children. This article is a scoping review, and it's the first article to propose a review existing of evidence. What is the evidence of working with children that are at high risk with CP or that have CP that are ages 2 and under. The methodology they used for this research was a framework by O'Malley and then later expanded, but these are the 5 proposed stages. So looking at the research articles, and you'll see that they narrowed it down to 8. So identify research question, relevant studies, select studies, chart the data, and summarize the results. So their main question in this research article was, does the research show that it's feasible to implement a CIMT protocol for infants age 2 and younger with a diagnosis of CP or at risk? So specifically looking at peer-reviewed studies for infants with a diagnosis, 24 months or younger. They looked at research articles over a 20-year span, year 2000 to 2020. Total articles included were 8. So there are 2 RCT trials, 1 retrospective cohort design, 1 pre-test, post-test study, 2 single subject studies, and 2 case studies. And for me personally, this is what I find interesting, is I want to know the dosage of the protocols and what did they do. So 2 studies use it's called Baby CIMT, and it's actually a program that's established out there, and it's used mostly in research. The first Baby CIMT research article came out in 2014, and that's also in the reference. And in the reference, it talks a little bit about what Baby CIMT is well. But for this study, and included in the 8 studies, the intensity of these 2 studies is 30 minutes per day. So that's what you'll see in Baby CIMT. The frequency, one study was 6 days per week, the other one 7 days per week. The duration was a 6-week period, and then a break for 6 weeks. And the research article talks about for the Baby CIMT, the 6-week break is really an analysis time to see what progress the child has made, and then they can restart the 6-week period. Okay, the other 6 studies varied. So as far as intensity goes, average of 1 hour per day to 6 hours per day. Frequency 5 days per week to 7 days per week. Duration 2 weeks up to 8 weeks. So the 3 studies allowed intensity to be separated into small increments during the day. And 2 studies were the non-removable casts. So a fiberglass cast, 24 hours a day, 7 days a week. And within the studies, all the CIMT principles were confirmed to prescribe dosage established by the protocols. Okay, so the protocols they use were, say if you put the cast on, they had a protocol of how much therapy intervention, for example, parents are working with the child or the therapist specific working with the child. Okay. And where did this take place? The 8 research studies, all of the studies included the home intervention, which makes sense when you're talking about natural environment. 2 studies was home and clinic, and 6 studies were in the home only. And the interventionists, so who were involved in carrying out that intensive therapy, working with the child to increase movement with the hand while for example, while their cast is on the non-affected side. So 7 studies included parent involvement, 5 studies, parents only, and 2 studies, parent and therapist. And there was only 1 study with just 1 therapist only. Okay, and this is the other area that I always find is what type of constraints are they using? It's called gentle restraints, is most commonly used with infants and I'd say toddlers, in using mitts, a glove in these research studies, allowed for gross motor movement. And so, and tried, and I have put a cast on a small toddler before that had poor balance in it. And I had to change that to a soft mitt, just personal, just because it threw off their balance. So I could see why you would want a soft mitt, which is going to be less weight on one side. And so to help with their balance, the resting hand splint was covered in one study. So they had a resting hand splint and they covered it with a soft mitt. And then 3 studies, there were casts were used, 2 non-removable and 1 that was removable. And with all the constraints, and again, this is what I find I want to know is, of all the 8 studies, there was no adverse effects observed in the non-affected upper limb. And if you go back to, I think the most intensive one was, it was on 24 hours a day for 7 days a week. And that's a long time to have your non-affected arm covered, but it shows there was no adverse effects on that. Okay, so parent training. So in the research, it talked about how this is a very vital component, and it's kind of obvious that's probably going to spend the most time with the child. 7 articles had direct parent training or a specific home program. Home programs were all individualized. 2 studies reviewed motor learning principles, including task practice, specifically repetition and shaping. And 1 study trained parents in activity staging and the use of positive reinforcement. So for all the studies, there was some type of parent training, but it's interesting that they were all a little bit different. Okay, some of the results or outcome measures. What they used was the PDMS, so the P-Buddy. They used the Bailey Infant Motor Scale. So that was the 3rd edition of that, to measure for fine motor component. They also use a video analysis, but they didn't actually use that in some of their final results. Their final results were measured by the P-Buddy, the Quest, the Mini AHA, and the HAA. And the Quest is the quality of upper extremity skills test. And the Mini is the hand assessment for, the HAA is the hand assessment for infants, and the Mini is the assisting hand assessment. So for the P-Buddy and the Bailey, once you have the test and you learn it, you can give it. But these down here, all of these tests require extensive training. And the Quest, the Mini, AHA, and the HAI, I have not ever administered. It does take extensive training for that, but I have administered these other assessments up here. So all outcome measures used in the 8 studies showed either significant findings or positive clinical findings to support the use of CIMT for infants with CP or at high risk CP. Okay, in the discussion, they talk about moderate strength as far as evidence goes, small number, 8 studies. And when you're looking at the research pyramid, the high being like a Cochrane review, the lowest being background information. So you have systematic reviews, clinically appraisal topics, critically appraised individual articles, and then you have 4, which is RCT's random controlled trials, and 5 cohort studies. So low-level study design, and the sample sizes were also fairly small. So it provides some preliminary support for an infant CMT protocol, information to guide for future practice, what else needs to be done. And for example, when I was thinking about it, is maybe some consistency with training parents for the home programming. Higher level studies are needed to make critical recommendations of the efficacy of CIMT for the infant population. And even today, there's a wide variety of protocol designs that are used, along with different types of constraints, such as MITS versus CAST. Now there's soft CAST, which is used quite a bit. And I'll talk about that in a little bit. So lack of consensus in protocol design. So if you get a research article, often you're going to find a different dosage that's being used. The recommendation was for profession to come up with some type of what's the minimal dose needed for CIMT to get benefits and gains, and is there a standard dose from CIMT? And as of today, I haven't. The most it's in the reference that I've seen is that baby CIMT. Okay, and what are the most appropriate constraints for infants? All 8 studies were done in the natural environment, and the importance of home programming training, parent education, and parent training. Okay, here's some information, just a little bit about the use of assessments that were provided. Variety of comparison group limitations. So as far as bimanual therapy, care as usual. So this is, if you can think of what the parents are carrying out that intensive therapy, or the therapist doing therapy. So they're doing group therapy, bimanual therapy, or just as they put the cast on and it's sort of care as usual. Some studies have baby massage, and sometimes they just put the cast on and there's really no intervention. They send the parent home over the weekend and just say, okay, have the child use that arm as much as possible. Okay, there are some recently published CMT guidelines, and there's the reference there by Morgan. And they're also in the, I have in the reference is from AOTA. There's actually a book. It's about CIMT. It's a pretty good reference. I looked up the price. It's about $90. Okay, now we're getting to, this is kind of my thoughts. What I thought about the article, and just a little more information that this is just me. But when you think of early intervention, and this is what really made me choose this article, that neuroplasticity, the focus on providing CMT for like within the first year of life. If you can think of that neural reorganization, and providing some type of intervention, intensive, or even if it's low dose, to help with that. And there's a lot of popular science information out about there about performing activities, habit performing activities. And most of the research articles there was about 5 that I studied, including this one, most of the interventions are about 4 weeks. And if you think about, okay, 4 weeks, well, that kind of ties in with if you're going to make a change where you start to see a actual change in the synapses. According to science, it's about 28 to 30 days. So that would make sense that you would want your CMT program to be at least 4 weeks. So on average, 4 to 6 weeks is what you see. Definitely continuation of research, and hopefully we'll come up with some more establishment of protocols. The other thing I thought about was, say you do your research, you're intensive within the first 2 years of life. I was curious, I didn't see anything in the literature about long-term outcomes. So say now they're 6 or 7, the kind of the correlating with the dosage of treatment. And I have a feeling that's going to be coming as there's more research with small infants. The natural environment. So some of the research was done in the clinic. And I think with the parent involvement, the caregiver involvement, it's probably hard to actually research, because I think there's going to be some caregivers that are more invested. They're going to be more involved. And if you do anything in pediatrics, definitely have some caregivers that are more involved, more intense, and some that are, I'm not saying they're less of a parent at all, but sometimes a little more laid back, maybe do less as far as when it comes to therapy. And I'll talk a little bit about that on my case study that I had. So even though in some research, so for example, the Cochrane review that I have in the reference, it talks about low evidence. And I think that's just a Cochrane review. And there's enough research out there to have a Cochrane review, even though when you read out there low to minimal evidence, that's still evidence that we can use as therapists to implement into our practice. And I think mitt, glove, or sock, or even if they have a long sleeve, for example, putting on a clip at the end of the sleeve, just blocking so the infant, their non-affected side. For me personally, I've had the best success with that rather than a cast. And I've also used a bivalve cast, which I'll talk about. So if casting, this is obvious. It's kind of like if you're going to do e-stim, or if you're going to do another intervention like using different PAMs, you're definitely going to want some training. So if you're doing any casting, make sure you have training, because you can, if you put the cast on, you can cause damage. So that's kind of obvious. Okay, a little bit more of my commentary. One thing that CIMT tries to avoid is that developmental disregard, and you'll read that a lot in the research. So as child, if they're it's almost like that neglect if somebody's had a stroke to the side that's been affected. But for children, it's that developmental disregard, which you're trying to avoid. And what you're trying to implement is activity-dependent cortical reorganization. Okay, neuroplasticity, basically. So I already mentioned this a little about parent motivation, parent involvement, parent routines. And this made me think about those tests like the Peabody, the Bailey, the other hand assessments. It just made me think, is there another assessment that we could use out there that kind of taps into a little bit more of occupation-based? For example, looking what the child's doing with their self-care. And I think it's called the I Acquire research study. I have a feeling, I think they are going to do some more self-help or self-care activities to help with the research, and to use that more as identifiers for progress. So every child is different too. You got to take that into consideration. Some are motivated, some are, I think the average most recent study I saw on children with CP, it's anywhere from 20 to 25% of them have some type of a cognitive delay. So that can affect your research, and something to take into consideration in your own practice. And also, as I mentioned, the focus on occupation. And one thing I like about all these research articles is basically there's no harm. So it can be done safely if you kind of fall within those bounds of the recommendation. 4 to 6 weeks for the duration, and some use non-removable casts, and some where it's removable. So this is a child that I work with. And but regarding the research article, are there any questions or any other comments? Okay, So this is my case study. This was a 2-year-old that I worked with a child a number of years ago. Mom was in a severe motor vehicle accident, and the suspect is that kind of is what caused the child to have a stroke in utero. And so he had left hemiplegia, had minimal movement with his hand. Initially, when I first saw this little guy, there was absolutely no grasping ability. The family was semi-cooperative, so they had really good intentions, but there were 4 other older siblings, and mom was super busy. With the child, I didn't see any significant cognitive delay, so he was socially appropriate, typical 2-year-old behavior. This mom, because of her busy schedule, at first she was very skeptical of CIMT, knowing that she would have to do a little bit more for her child. So we started off slow. I started off with a soft cast. And if you're familiar with that, it goes on, it looks like a fiberglass cast, but you can peel it off kind of like a banana. We started with that, and we just did a trial period of overnight. And then once we did that, had successful times with that, we went to Friday to Monday, to where it was, we again went with the soft cast that was non-removable. And then we eventually moved to a bivalve fiberglass cast. So you put on the cast that's fiberglass, and then you just cut it on the ulnar side and then on the radial side, and it opens up like a clamshell, and then you redo the padding, and then we just use an ace wrapped it back on, made it so the little guy couldn't take it off. And that seemed to work best for this family, so you can come up with different ways on that. So with this little guy, we started with OT in the home, and then I actually did the casting in the home. And during our therapy sessions with her, I saw him about twice a week. And then after I saw him, I had the mom do a lot of family facilitated activities. We had even the older children involved in therapy. He was not in preschool yet, and he made some significant progress. And I used the P-Buddy, and at first, I wasn't even able really to get a score, but with some different activities, mostly for just functional use of grasping, but he was able to use his hand to where he had fairly good grasping skills. He could raise it above his head. Initially, he could not raise his arm above shoulder height. So a lot of the progress was measured by family report, by observation, and using different grasping activities during OT sessions. For this particular case, the Monday to Friday was the maximum we were able to get. And we would do intensive for a month, take a break for a month, and then we'd do another intensive for a month. And just because of family schedule, dad happened to be a physician, and so he was super busy, and they went out of town a lot. Some of the therapy was interrupted a little bit, but overall had pretty good progress and success with this little guy. There was some other cases that I've had in the past where I've worked and have some good success, and so I am a big fan of CIMT. Let's see, I'm down to the references. There's the reference of the actual article that we reviewed. And the second one there, the Handbook of Pediatric Constraint-Induced Movement Therapy, I would highly recommend. It came out in 2013, and you can get it through AOTA. And this iAcquire study, which I was talking about, is one of the principal investigators is Catherine Hoyt out of Washington University in St. Louis. But they are comparing 2 dosages of children 8 months to 36 months. So they're comparing a moderate dosage 3 hours a day versus high dosage intervention 6 hours a day, 5 days a week for 4 weeks. Okay, and then parents practice at the home doing the intervention with specifically their affected side for 45 minutes a day. So I've been looking for that research article. It should be coming out soon. And I've been told it's going to be an ongoing research study. It has like 12 different sites in the St. Louis area. And also, I mentioned earlier, the first published baby CIMT article was in 2014. And if you research baby CIMT, the training is 30 minutes a day for a total dosage of 36 hours, 6 hours a day for 6 days. And average is they go, and I believe it's 4 weeks. There is another good article. This one, it was published in 2018. It's called the CHAMP article, Children with Hemiparesis and Arm Movement Project. So this research article is probably good to note out there if you want to, but it also talks about constraint-induced movement therapy and showing the success. And I thought I'd just throw that in there as a reference. Okay, this is the actual Cochrane review that I was talking about, where I think it looks at 36 different research articles, and they talk about, in this one, the evidence is CIMT with low dose therapy. So they compare low dose therapy. I think the average is 7 hours a week, that they say that CIMT definitely has great benefits. High doses CIMT with CIMT with high doses therapy, it was around 59 hours a week. They found no comparison, which I found very interesting, meaning that if you're doing high dose therapy, if I'm doing like close to 58 to 59 hours a week with the child, working with that affected arm, according to this Cochrane study, it showed that it was comparable to CIMT, which to me tells me that the benefit of therapy intervention not only was helping to improve a child's affected arm, but probably with other areas of benefit. So this is an interesting art. It's pretty long. It's 277 pages. So be prepared if you read that one. Okay. And I will stop sharing. Or I will try to stop sharing. There. Okay, are there any questions?
Corwin, is there ever a time when it's like too late to do constraint induced?
Good question. So one of the oldest children I started with was a teenager, and was in I'm not sure the age, but was a junior in high school. And it was a discussion, and this is just a personal case study that I had when I worked with a child, and discussion with the parent that we thought we'd give it a try. And I'll tell you, it was really, really hard for this teenager to put on the cast, because they're so used to doing things throughout the day, and they found it very troublesome, and actually came back a little earlier because I started with a fiberglass cast. I wish I'd done a little bit slower. And so we came back with the fiberglass cast and we cut it off, and we went a little slower because it was probably affecting this particular child a little bit more kind of mentally. And so we cut back a little bit more. We started doing things in therapy, and then slowly worked up to a little bit more. But both mom, this boy, and myself, we saw some benefits. We saw some things that he was doing that he wasn't doing before. And I probably saw him for about 2 years before I actually moved out of the area and turned him over to somebody else. So, and if you think of even with adults, as far as somebody that's had a stroke or something, the sooner is better. But with this child, I think he was 17 or 18, we saw some benefits. When you're talking about neuroplasticity and organization, maybe there was some of that, but I think his arm was getting a little bit stronger, and the coordination was getting a little bit better when you think of just about the muscles. And we were also at the same time working on range of motion. So I think it's worth a try. I can't think of any research articles that I've read with older children. That's actually a good question.
So that does segue into my world of exposure with constraint in adults, where it just seems like that'd be the hybrid of now you're in that in between. You know, I was seeing people in their 50s plus post-stroke, some of them more recent to post-stroke, like 6 months, probably that is generous, maybe more like a year. But I was seeing people that were like 6+ years post their stroke. So we'd imagine, you know, obviously neuroplasticity is still possible, but changes, I imagine, look very different in the adult population compared to doing this with the pediatric population. Like you're catching them as they're developing. I'm catching them trying to remediate after an injury, or I was when I was working in this area. Where I think a lot of, even we just covered this in class, where even videos of pre-test, post-test, it's not this beautiful, like normal movement again. I mean, certainly it can become more coordinated, more refined, but I think a lot of the results really just come with, they figure out how to use what they have, and they improve their skills to some extent, but a lot of compensation can still be present and whatnot. But yeah, I think I would say for sure, like there is no such thing as too late, because especially if we're still talking about the teenage years, you know, there's so much life ahead of them. If you can figure out a way, and that's where I would probably be a proponent for casting so that it's permanent, to force them to actually use their affected side, if that's feasible.
Yes, thanks, Brittany. That's great comment. When I think about sometimes how we measure, I love videotaping. And when you look at some of the research articles, I think sometimes, yeah, there's some standardized assessments which you use, which kind of falls within the bounds of good research. But I wonder if there's a better way that we could measure progress, like the video, and with functional activities, which kind of falls in line with what we do every day of occupation.
And that's where, like in the adult world for constraint, we use the Wolf Motor Function Test, which is like the Jebsen-Taylor hand, whatever function test. I forget all the acronyms of it, but the Wolf, I mean, it's a time-based test and it's doing functional activities. And then we videoed it as well for pre-test, post-test, and just sharing the, you know, the subjective observations in conjunction to like the objective time changes, because sometimes the time maybe wasn't drastic or significant, but the quality of movement looked a lot better, or whatever, or at least just the participation in the activity could be improved. But I had a question segueing off of that. So when you, well, not really totally changing, but when you were doing this, what setting were you in? Because I guess that was like the thing that when I was working at St. Luke's in Boise, coming up with this program and how to follow through with reimbursement and insurance and all of that stuff, it's pretty hard to justify. I mean, we were able to do it, but it's hard to justify therapy every single day, especially if you were in a home health setting. Because I had a client here in the eastern side of the state that I would have been a great candidate for constraint. This kid was 3 with CP. And I saw that kid 1 day a week, you know, like you can't do it that way. So I was just curious, what setting were you in, and how did you design it? And did you run into, or any tips for practitioners out there of how to design this in a more traditional setting when you don't have like a formal constraint program, or somebody that's saying, yeah, go ahead and see them 6 days a week, like, and take all of their benefit for just
Yeah.
OT.
Yeah, and that's one of the problems with reimbursement and with how our medical model is set up. Because to be honest, with all the children I've seen when I've done CMT, it's about once a week, because that's about what their benefits provided. So the home health therapy was it started out to be twice a week, but it got cut back to once a week. So on average, I saw that little boy once a week. And then the other was mostly for out on an outpatient basis, which was once a week, maybe sometimes twice a week, where I saw them on a Friday and we did a follow-up on Monday. So that was an outpatient clinic in a hospital-based setting of most of the CMT. That's the material that I used was from the hospital. For the home health agency purchased that, and specifically for this individual case. And I had to get the water, get the casting material. You have to have the scissors and the wrapping material, and it was kind of a pain to get it all to the home. But once I did it in the home, and if I had to do it again, I would have still done that, because the mom was so invested watching me make that in her home, and the kids were there watching too. It's like the family was all interested in watching it. And so if I had to do it again, I would try too much as possible, more than once a week. But I would have done a better job on training the parent, and almost having like a specific program during the day, and even having her maybe keep track a journal article, how much time is she spending, and a little bit to hold her accountable a little bit. My other specialty is feeding, and sometimes I'll have parents do feeding logs just to kind of hold them accountable a little bit of what they're feeding their child. So I think I would have done that. And the technology we have today that I never even thought of back years ago when I was practicing doing CMT is like telehealth. Doing a telehealth session where in my practice right now, I do a lot of telehealth for feeding, follow up with kiddos that are a long ways away, and I can watch them eat. And I think that's a little bit maybe a wave of the future, is to provide more of that. And how do and still looking at the reimbursement. And there are some cases where, fortunately, my manager in the hospital knew that we couldn't bill for the casting material. And there's some codes on that too. So my manager said, it's okay, it's one of those things that is service we provide. And so I would bill it under like I'm working with the child on manual therapy. So I'm billing it activities therapy direct. I hope that answered the question a little bit of how I manage it. But on average, yeah, just sometimes you're dictate a little bit of what their insurance is.
Yeah, it just goes back to show like how important, it's got a little baffling, some of the studies that did not involve parental involvement, because how could you? How could you not?
Yeah. And the research studies I read on that, their explanation was, and I get this, is if you have a therapist doing, it's more controlled when you're doing the research study. If you have a parent doing it, then it's less controlled. And a lot of them tried to make up for that by having the parents keep a journal and the amount of time and kind of what they did. And so I see that in the research, but I just don't think how you could do it without the parent involvement and having them involved in some way, and maybe even putting more on their shoulders. Hey, you're going to be part of this research study and help out.
I have a question, Corwin.
Yeah.
How often do you repeat the protocol? So you said do it for 4 weeks, and then do you wait a certain amount of time and then repeat the protocol, or do you revisit it at all? How is there any recommendation on how frequently you should do it?
On what I saw first of all, I'll start with the literature. What I saw was about anywhere average 4 to 6 weeks. And I think then you're tapping into that neuroplasticity, the neural reorganization of the synapses. And then they took a break. The average break was 4 weeks. And I think you're giving some time for the explanation I saw in the literature was you're not always blocking the affected arm. I mean, the non-affected arm. So you don't want to cause any inhibition to their arm that's their non-affected arm. So I think that was the rationale in the literature, is so now you give them 4 weeks of using hopefully 2 hands together and still using that non-affected arm. And then you're going back to it for another dosage of, say, 4 weeks. And I think as far as, okay, how long do you do that? That's a good question. And I'm not 100% sure. Just with the children that I've used that same model for about maybe 4 or 5 months. And then we take a break during the summer when they're going to be swimming and some other activities, and kind of revisit again in the fall. And sometimes it is caregiver driven for me. If I've had some parents say, hey, they give me a call, it's been maybe a couple months, hey, we need to get back in and do some more CIMT. So I think directly working with the caregiver and good communication to know how the child's doing. Are they continuing to make progress once you have a break from the cast or the restraint? Hopefully that answered your question, Soraya.
Yeah, thank you. That did.
Corwin, do you think that this is kind of the gold standard for CP? Do you think there's a lot of practice using this model out there? Because it just seems like it should be.
That's a good question. I don't think it's used as much
yeah.
as it could be used so much more. And I think when you think of CMT and this was and actually I've listened to a couple different podcasts on CMT, some people that researchers that do that. I think it is some people think, oh, I need to be specially certified in this or trained in it. And really you don't. And that's what the researchers are saying, that look at some of the dosage, even if you're doing low dosage, that it's having some benefits. And so I think it is underutilized, and not just in Southeast Idaho or in the state of Idaho. I think it's nationwide that's being underutilized. And part of it is just knowing that it's available, and then how do I go about using it? And I think if it's an infant and if they have a long sleeve and you're just tying a knot in the end of the sleeve, that's still something to do some low dose and involve teaching the parent. But knowing that, okay, if I do this intervention for at least 4 to 6 weeks and pretty intensive therapy and what's allowed as far as insurance goes, I think anything is beneficial.
And I think that's why there's so many different variations in how to design it, because there's, what's in the research, which, who's going to do 6 hours or even 3 hours of therapy a day, especially with an infant. That would be really hard, I would imagine. And then who's going to reimburse that? Not seemingly a lot of places or insurance providers. But then, then there's concepts that we can apply. So I went to University of Alabama, Birmingham. They have a constraint training program to design your own program, and they have an adult section and a ped section. So there is formal education out there, but I think it's still like take that and then modify it into like how you can implement that into your practice. And I think that's something that I would try to bring even in the adult population, of the same idea of, can I do a lot more repetitions, and can I get them to have some sort of home program where they're even putting their hand in their pocket, their unaffected side in their pocket, to try to force use for like normal things of like tucking my hair behind my ear, or scratching my nose, or turning the light on, or flushing the toilet, just those automatic things. Like I would think for kids, I mean, it's just, like it's just, it would be sad to not have that education and training. There's just so much that could be done that just makes sense neuroplasticity wise, that would be monumentally important and make a lot of progress. But you picked my favorite topic, so thanks for talking about it.
Yeah. Well, I was just looking for a good recent research article, and I saw this and I thought I haven't done it in a while. I mean, my bread and butter is feeding and the NICU stuff. But when I saw this research article and kind of getting back to all the different dosages that are out there, in a way, part of me thinks, well, maybe that's appropriate because every family's a little bit different, every child's a little bit different, and maybe that's an opportunity for us OTs to create that occupational profile to match the family and working with the family. So when I first started reading, I was looking for, I want some concrete evidence to know what's the correct doses. But I think if you have an idea of what the range is and what I can do, it probably is going to be a little bit different for each family.
Yeah.
We'll see what the future research brings.
I can be, well, I guess we're not that far over, but I can be respectful of people's time. But Megan brought up a good point. And Corwin, can you put your email in the chat so people have access to it? And then I'm just going to throw out there something also. If you did not get an email, I'm slowly putting together the most comprehensive list of people that want regular notifications. So if you did not get an email notification for this journal club and you would like to be included on future journal club notifications, please put your email in the chat and then I will make sure you are on that list. And then can I be rude, not rude, but can I call Soraya out and can you say who you are? We went through everybody else and you're a name that I don't recognize. So I am excited to see a new face. Are you still there? Yeah.
Yeah, I'm here. I'm Soraya. I just moved to the area actually, and I work at speech therapy services, and I'm an occupational therapist. So.
Awesome. Welcome.
Thank you.
I always like having new people, so that's awesome.
Yeah, thank you.
And then go ahead, Corwin.
Oh, sorry, I was just gonna about I threw my email out there. The emails I see, I'll write down. But if you didn't get something, just send me email and I'll be more than happy to send you my presentation.
Corwin, this is Megan Doyle. I will be reaching out to you about presenting at IOTA annual conference this year because we have lots of requests for peds and feeding and NICU. And I've heard you present before, sir, and you are just a delightful presenter at the ISU OT Treatment Summit, the Student Summit. That was, I think, 2022. Yeah, April 2022. So I will be reaching out.
All right, thank you. And I wrote myself a note here. I'm going to be joining IOTA. I don't know why I'm not a member, but I am joining right away. And I appreciate everything that IOTA does. And I just realized I'm not a member, but I'll be joining right away.
Okay, well, fantastic.
All right. Well, thank you, Corwin, so much. That was really awesome. And thank you all for being a part of this. So just a reminder that if you search on YouTube, ISU OTA, we have a page. That's where I post all of this. So if you are, really excited about past topics and you want to listen, all of our our past topics that we've recorded are posted on our ISU OTA page. And then just a little plug, like I just renewed a certification that I have and I used, I have demonstration that I participated. We're talking about valuable things. So these do count as PDUs. We don't have it formally set up for CEUs. That's a goal for the future, but this is something that can count towards your licensure renewal and your professional development. So we're hoping to make that more formal, but you can certainly be using what we have right now to benefit you because I think this is a pretty awesome thing that we're doing. So thank you guys for being a part of it. And a plug for the next date because I actually have a topic. So Anna Alexander is presenting on Tuesday, March 7th. She's talking about burnout for healthcare providers. So I think that is another very relevant topic. So set the date, mark your calendars, and then I'll be looking at promoting that here soon. And I don't have topics for April or May. So if someone has a burn for, I would love to talk about this, or I would love to hear about this, then that gives me some direction on what we can do to make this meaningful to more than just myself.
I apologize because I already know I'm going to have to miss next month. I have another required meeting like directly conflicting. So that's a bummer because I wish I was there for burnout, but just know that we're going to keep spreading the word for IOTA and try to get even more practitioners and students on.
Awesome.
Perfect.